welcome again to another edition of the Osteopathic Lyceum podcast. Going to consider clinical practice guidelines more. So in order to flesh this out so that as a responsible professional, I'm not leaving anything on the table in the way of being uninformed about a topic that somebody has presented to me. So again, if you've watched a few of the more recent podcast episodes, what day is today? Today's April 13th, Monday, April 13th. So I'm recording this. This won't end up published until sometime in June. But if you've consumed a few of the more recent ones, you'll note that I'm looking at things that somebody suggested I looked at to better understand a particular topic in the form of evidence-based medicine and evidence-based practice. The initial curiosity for myself was whether or not within best practice guidelines, the treatments contained within the best practice guidelines had been compared to prior standards to note that there was better outcomes, and I was told that that would be contained within best practice guidelines or clinical practice guidelines. So just looking around, trying to find things, not necessarily generating what I would call a perfect search, because then that would probably put me, no, that's not even fair. It's probably more fair to note that any search has issues, and you're going to find something, maybe you're missing something, but at least you're aware of that possibility. So one of the things I was looking at was, I think it was best practice guidelines for shoulder issues. And I came across a few papers. I'm just going to read through the abstracts. I'm not going to go through the full papers because the abstracts have what I would call appropriate highlights that, based on my current level of confidence, continue along the line that the best practice guidelines don't necessarily properly compare previous approaches to whatever is contained within the best practice guidelines, or those best practice guidelines are really just kind of developed off of a pattern that has already been noticed, and you just say, let's do that. So something that somebody was already innovating and doing, let's just do that. Now, the manner in which the best practice guidelines or clinical practice guidelines are developed have issues, which I've touched on previously. So I'm just going to read through a few of these abstracts. The first one is Philadelphia Panel Evidence-Based, just because of how this is laid out on my phone, it looks a little funny, so please let me read that again. Philadelphia Panel Evidence-Based Clinical Practice Guidelines on Selected Rehabilitation Interventions for Shoulder Pain. This is from 2001, so it's older. The point of this was to develop a way to develop best practice guidelines, as far as I can tell. Anyways, to read the abstract, introduction, a structured and rigorous methodology was developed for the formulation of evidence-based clinical practice guidelines, then was used to develop evidence-based practice guidelines, clinical practice guidelines, for selected rehabilitation interventions for the management of shoulder pain. Methods. Evidence from randomized controlled trials and observational studies was identified and synthesized using methods defined by the Cochrane collaboration that minimize bias using a systematic approach to literature study selection, data extraction, and data synthesis. Meta-analysis was conducted where possible. The strength of evidence was graded as level 1 for RCTs or level 2 for non-randomized studies. So they're just telling you how they did it. My initial contention with respect to best practice guidelines, which has been sort of borne out in previous episodes, is that it's an aggregation often of systematic reviews. So it doesn't necessarily mean that it is an aggregation of systematic review, but it's built by systematic review, and then you can do a systematic review on systematic reviews, and then it gets really meta. The evidence hierarchy being the standard evidence-based medicine or evidence-based practice hierarchy with RCTs sitting below meta-analyses, and then the best practice guidelines being based on systematic analysis or systematic review and built above that. So the simple thing is, if there's any flaws in the RCT, if there's any flaw in the non-randomized trial, it gets put into the meta-analysis, which then gets put into the best practice guideline, which, if you don't know what you're looking at, you wouldn't detect, right? So you've got to be aware that you have to look for the flaws in these things. Otherwise, if you accept whole cloth the evidence hierarchy or the preferences of somebody who's developed a system prior to you, and you don't check it, then you are just imbibing their flaws. You're drinking their flaws. You're making their flaws part of what you're doing. So it has more value to check these things because everything has flaws. It's just whether or not the flaw is going to impact what you're using it for or what you're doing with whatever the output is. To read again, developing recommendations. An expert panel was formed by inviting stakeholder professional organizations to nominate a representative. So you go to organizations. Those organizations could all have agendas. The individuals that you nominate could have agendas, and they're going to push them. It doesn't mean that they will. It just means that it's possible. Right? So that possibility, you have to have some curiosity about at minimum. This panel developed a set of criteria for grading the strength of both the evidence and the recommendation. The panel decided that the evidence of clinically important benefit defined as 15% greater relative to a control based on panel expertise and empiric results. Okay. Had to be would need to see the full paper to understand what they mean by control. It could mean some kind of, it's not comparison, so it's not necessarily comparing it to another intervention. It could be compared to nothing. So it could be 15% better than nothing, right? So let's just say we have a value of 1. So 1 in 100 people get better with doing nothing. Then we need 1.15 people to get better with the intervention. I'm not sure that that's what this is saying, but if it is, then that's not evidence that the clinical or best practice guideline or clinical practice guideline is better. It's better than nothing. I'm not sure that that's what it's saying. So keep in mind, I am expressing low confidence in my current interpretation because I'd need to see more to be able to have a confident interpretation. But right now, this sounds a little squirrely to me. Like just say 2 out of 200 people or 2 out of 100 people get better. Now we need 2.3 people to get better. So if 2 out of 100 people get better from nothing, we need 2.3 people to get better. Anyways, and it's based on the panel expertise and empiric results. So the panel expertise might be able to override the empiric results. Anyways, statistical significance was also required but was insufficient alone. Patient-important outcomes were decided by consensus as being pain, function, patient global assessment, quality of life, and return to work, providing that these outcomes were assessed with scale for which measurement reliability and validity have been established. Yeah, fair enough. Like if you've got tools that have had validity studies. Validity studies are usually the ones that you're going to look at. Contained within that, you'd see the reliability often. It also depends on what kind of validity you mean. There are different types of validity. In 2001, there wasn't as many types of validity explicitly described. Technically, they would have existed, quote unquote, but they weren't necessarily described in 2001. So I would want to know which specific type of validity they were talking about. Fair enough. To read again, validating the recommendations. A feedback survey questionnaire was sent to 324 practitioners from 6 professional organizations. The response rate was 51%, which is actually high for surveys. Surveys have the constant problem that the people who answer surveys have generally similar profiles as far as their characteristics. The first way to tell that is that they'll actually answer the survey, which means that there's likely other traits that are similar that they bring into that. Anybody who doesn't answer is not represented. So 51%, for me to lean into 51% of people within a dispersed group or a diffuse group saying certain things, that's not going to cut it for me. It doesn't mean it has no value. It just means it's not going to cut it for me because I want to know what the other 49% are thinking, why they didn't answer the survey. Well, if I go ask them, they're probably not going to answer me. There's something going on that keeps them away from it. I'm not sure what, but there's something that keeps them away from answering. Anyways, to read again, results. Only one positive recommendation of clinical benefit was developed. Ultrasound provided clinically important pain relief relative to control for patients with calcific tendinitis in the short term, less than 2 months. There was good agreement with this recommendation from practitioners, 75% of the 51% who answered, for several interventions and indications, e.g. thermotherapy, therapeutic exercise, massage, electrical stimulation, mechanical traction. There was a lack of evidence regarding efficacy. So they didn't know if it if these things actually did anything, even though they recommended it, or if they did enough. Conclusions. This methodology of developing EBCPGs, evidence-based clinical practice guidelines, provides a structured approach to assessing the literature and developing EBCPGs that incorporates clinicians' feedback and is widely acceptable to practicing clinicians. Further, well-designed RCTs are warranted regarding the use of several interventions for patients with shoulder pain where evidence was insufficient to make recommendations. So the RCTs need to be better. The base level investigation that would inform the systematic review needs to be better. So the foundational science is being suggested as needing overhaul or improvement, which would be my general contention most of the time. I'm going to be less concerned about systematic reviews until the base science is better. All right, so that's that one. I'll go to another one here. So what are we getting now? What we're getting is that it's hard to get to something that actually seems to work better than control. And the only thing at the time in 2001 was ultrasound to the shoulder for specific forms of pain, the calcific tendons. So if you do a lot of work and you only get to one recommendation, maybe that isn't worth it. And also not everybody's represented there. I'm going to read another one here. Oh, there it is. July 2020. So this is from July 2020. Shoulder rotator cuff disorders, a systematic review of clinical practice guidelines and semantic analyses of recommendations. So semantic would be meaning, right? So what do these things mean? There might be something more specific with respect to semantic analyses, but that's probably close enough. This is again from 2001, and this is the abstract, okay? Objectives: to perform a systematic review of clinical practice guidelines and semantic analysis of specific clinical recommendations for the management of rotator cuff disorders in adults. Data sources: systematic bibliographic search was conducted up until May 2018 in Medline, Embase, and Physiotherapy Evidence Database, or PEDRO, PEDRO. Oh, yeah. Okay, right on. Databases, in addition to 12 clinical guidelines search engines listed on the appraisal of guidelines for research evaluation website, the AGREE website. Study selection: 9 CPGs on the management of rotator cuff disorders in adults or workers, available in English or French. It's nice when you can have more languages. So when you have a research group that can read papers in other languages, that does do something positive. That is good. And published from January 2008 onwards, so 08 to 18, 10 years, were included and screened by 2 independent reviewers. Data extraction: CPG methodology was assessed with the agreed-to checklist. A semantic analysis was performed to compare the strength of similar recommendations based on their formulation. So if they seemed similar, that's what they were using that for. To read again, the recommendations were categorized in a standardized manner considering the following 4 levels: essential, recommended, maybe recommended, and not recommended. Data synthesis: methodological quality was considered high for 3 CPGs and low for 6. So they found a bunch and only 3 were high, right? So that suggests that when utilizing iterative methodology to assess through systematic review the clinical practice guidelines, which are often built through systematic review, they haven't been done all that well. Anyways, to read again, all CPGs recommended active treatment modalities such as an exercise program in the management of rotator cuff disorders, acetaminophen or nonsteroidal anti-inflammatory drug prescriptions, and corticosteroids injections were presented as modalities that may be recommended to decrease pain. Recommendations related to medical imagery and surgical opinion varied among the guidelines. The most commonly recommended return to work strategies included intervening early, use of multidisciplinary approach, and adaptation of work organization. To finish with the conclusions, only 3 CPGs were of high quality. The development of more rigorous CPGs is warranted. So the systematic review with the AGREE approach, or the agreed-to checklist, is suggesting that the methodologies thus far for existing CPGs has problems. Okay. To see the full text would give me more information here. But if you look at the commonly recommended return to work strategies, do something early, don't wait. This isn't impressive guideline development. Use of a multidisciplinary approach. The multidisciplinary approach is useful because you don't know which patient is going to respond to what. So you try a bunch of different things, and whatever they respond to best, you continue doing. Right? It's normal experimentation. It's normal clinical practice. Adaptation of the work organization. Change the work environment that possibly led to the problem or would exaggerate the problem. Anyways, to find the next one, just gotta let it come up. This is when's this from? 2015. This is 2015. Consensus for physiotherapy for shoulder pain. Right. So the abstract here to read. The purpose: shoulder pain is a common disorder despite growing evidence of the importance of physiotherapy, in particular active exercise therapy. Little data is available to guide treatment. The aim of this project was to contribute to the development of an internationally accepted assessment and treatment algorithm for patients with shoulder pain. Okay, so in 2015, there would have been clinical practice guidelines, but the evidence wasn't that strong. Who knew? Methods. 9 physiotherapists with expertise in the treatment of shoulder dysfunction met in Sweden in 2012 to begin the process of developing a treatment algorithm. A questionnaire was completed prior to the meeting to guide discussions. Virtual conferences were thereafter the platform to reach consensus. So some kind of video conference. Results. Consensus was achieved on a clinical reasoning algorithm to guide the assessment and treatment for patients presenting with local shoulder pain without significant passive range of motion deficits and no signs or symptoms of instability. So this is very narrow, right? Like all of these things have to be in place. Then you get to use the algorithm that they developed. The algorithm emphasizes that physiotherapy treatment decisions should be based on physical assessment findings and not structural pathology, that active exercises should be the primary treatment approach, and that regular reassessment is performed to ensure that all clinical features contributing to the presenting shoulder pain are addressed. So I'll continue to read and then I'll go back to something. Consensus was also achieved on a set of guiding principles for implementing exercise therapy for shoulder pain, namely a limited number of exercises performed with appropriate scapulohumeral coordination and humeral head alignment in a graduated manner without provoking the presenting shoulder pain. Conclusion. The assessment and treatment algorithm presented could contribute to a more formal, extensive process aimed at achieving international agreement on an algorithm to guide physiotherapy treatment for shoulder pain. If you set out one process that people are recommended and then possibly required by licensing bodies to perform at all times, then you're negating the variability between patients and you're actually more likely to cause harm because of your algorithm, on account of the fact that if a person it is being applied to, it does not appropriately apply to, you force them through it or you will miss things that an adaptable process is more likely to have the ability to catch. Diagnostic approaches are not necessarily easy because of the variability between people. And if you do get an international guideline and it is applied at regulatory level, you could actually be causing harm to the public because of the rigidity of it. I'm not saying that that's the case. I'm saying that that is a predictable problem. Anyways, to move back here, physiotherapy treatment decisions should be based on physical assessment findings and not structural pathology. One of the things I teach my students, one of the things that osteopathic practitioners worldwide are probably doing is working preferably off of the actual finding of the actual assessment that they do and not the image of the patient, because the structural pathology can be misleading. There is stuff available, as far as I'm aware, where they scanned healthy people and found a lot of anatomical pathology, but no symptoms associated with it. So somebody could have a horribly degenerated vertebral column and no reported symptoms. Their function could be, essentially fine with no complaints on their behalf. Things like tears in hips, labrums, and rotator cuffs, and no notable symptom, right? So people are in their world fine, but they do have anatomical pathology. If you use the findings of a test that you're not performing, then you are not applying treatment to the individual as they present. You're applying treatment to something that was done by somebody you are not, at a time that you are not in. And pathologies will change, but you're not going to be sure how if you don't have the imaging technology available to you and skill in utilizing it. So yeah, do a test. Whatever the test tells you, you treat based on that test in that moment, because that's how they're presenting right now, as opposed to some time slice that you weren't present in and you didn't do the diagnostic test. Range of motion, regular reassessment. This is just normal clinical behavior. You're supposed to check the patient now, not yesterday. You check them now, you treat them now, you see how it changes now, and you continue to do that consistently. Oh, wow. This is such an amazing guideline. Anyways, to go to the next one, should be, it's going to take a while because it's verifying that I'm a human. Because I'm clicking links out of my email. So it acts differently. Anyways, when is this from? Oh boy. This is from 2013, so a little older. Shoulder pain and mobility deficits, adhesive capsulitis, so frozen shoulder. Read the abstract and then I'll read some of the recommendations, because the recommendations are present without going behind a paywall. The abstract. The orthopedic section of the American Physical Therapy Association, APTA, has an ongoing effort to create evidence-based practice guidelines for orthopedic physical therapy management of patients with musculoskeletal impairments described in the World Health Organization's International Classification of Functioning Disability and Health, the ICF. The purpose of these clinical practice guidelines is to describe the peer-reviewed literature and make recommendations to adhesive capsulitis. So the recommendations: pathoanatomical features. Clinicians should assess for impairments in the capsulo-ligamentous complex and musculo-tendinous structures surrounding the shoulder complex when a patient presents with shoulder pain and mobility deficits, which is in brackets adhesive capsulitis. The loss of passive motion in multiple planes, particularly external rotation with the arm at the side and in varying degrees of shoulder abduction, is a significant finding that can be used to guide treatment planning. Move their arm. All of those words was have them move their arm or move their arm. If it's restricted in multiple planes, especially with external rotation, you've tested the structures. This seems like a lot of work for, hey, check how their arm is moving. Risk factors. Clinicians should recognize that 1. Patients with diabetes mellitus and thyroid disease are at high risk for developing adhesive capsulitis, and 2. Adhesive capsulitis is more prevalent in individuals who are 40 to 65 years of age, female, and have had a previous episode of adhesive capsulitis in the contralateral arm. Recommendation based on moderate evidence. Okay, so the first one, I should have read this in brackets. The first one, check their arm by moving it, is recommendations were based on theoretical and foundational evidence. So at least they're reporting the type of evidence, so you can adjust your confidence intervals. It's theoretical. I don't know if theoretical is proper there, but that's just me being nitpicky. Anyways, clinical course. Clinicians should recognize that adhesive capsulitis occurs as a continuum of pathology characterized by a staged progression of pain and mobility deficits that at 12 to 18 months, mild to moderate mobility deficits and pain may persist, so many patients report minimal to no disability. The recommendation here is based on weak evidence. Diagnosis/classification. Clinicians should recognize that patients with adhesive capsulitis present with a gradual and progressive onset of pain and loss of active and passive shoulder motion in both elevation and rotation. Utilizing the evaluation and intervention components described in these guidelines will assist clinicians in medical screening, differential evaluation of common shoulder musculoskeletal disorders, diagnosing tissue irritability levels, and planning intervention strategies for patients with shoulder pain and mobility deficits. The recommendation is based on expert opinion. So that could suggest that there's good evidence. It could suggest that the evidence isn't there. I don't know. But the expert said it. Differential diagnosis. Clinicians should consider diagnostic classifications other than adhesive capsulitis when the patient's reported activity limitations or impairments of body function and structure are not consistent with the diagnosis classification section of these guidelines, or when the patient's symptoms are not resolving with interventions aimed at normalizations of the patient's impairments of body function. 2 plus 2 doesn't equal Jell-O. I put 2 plus 2 into my calculator. The calculator said Jell-O. There's something that I'm missing. If it doesn't behave like adhesive capsulitis, maybe you should think it's not adhesive capsulitis. Whoever wrote this probably thinks their colleagues are dumb. Anyways, and used a lot of words. That recommendation was based on expert opinion. Examination to outcome measures. Clinicians should use validated functional outcome measures such as the disabilities of the arm, shoulder, and hand, the American Shoulder and Elbow Surgeon's Shoulder Scale, ASES, or the Shoulder Pain and Disability Index, SPADI. These should be utilized before and after interventions intended to alleviate the impairments of body function and structure, activity limitations, and participation restrictions associated with adhesive capsulitis. Recommendation based on strong evidence. So the strong evidence there would be that those were validated assessment tools, such that if you use them, you're likely doing things the same as other people. So inter-rater reliability, we find the same thing because we did the same thing, goes up. And also, if I really like meta-analyses, I can do a meta-analysis on the outcomes of these with greater ease than I can off of any other form of clinical reporting because it's not standardized. So the ability to do the math and import the finding of something that doesn't use this is way harder than using this. What this is a standardization of approach. If we use the same tool, we're probably doing the same thing. We'll probably find the same thing in the same person. So inter-rater reliability goes up. It doesn't necessarily mean that they're valid. They probably are valid because you would have to do a validity study for this. But it doesn't mean they're valid to the patient population. It just means that they're valid to each other. Anyways, that is based on strong evidence, and that strong evidence is going to be the validity studies and the reliability that has been identified, especially inter-rater reliability, because it's a standardization of approach. To read again, examination, activity limitation measures. Clinicians should utilize easily reproducible activity limitation and participation restriction measures associated with their patient's shoulder pain to assess the changes in the patient's level of shoulder function over the episode of care. Recommendation based on expert opinion. Use the same test that seems to allow the individual patient to understand what is the same and what is different. Use the same test. Test them one way, test them again the same way, test them again the same way, and then both you and the patient will be able to judge change. I don't know, just use the same damn test. Like, that's the way that you get to validity. So if I use the dash over and over again, then I maintain validity. I can say that it is what I am claiming is trustworthy because I did it the same way over and over again. If I use dash and then spatty, the validity drops off a cliff. Even if they're similar, it just drops off a cliff. Like, this is not... The intervention, so to read again, corticosteroid injections. Intra-articular corticosteroid injections combined with shoulder mobility and stretching exercise are more effective in providing short-term 4 to 6 weeks pain relief and improved function compared to shoulder mobility and stretching exercises alone. Recommendation based on strong evidence. That strong evidence would have come from RCTs looking at corticosteroid injections versus stretching and mobility alone. So that was already done. So you're importing the level of evidence that exists based on something that was already there. You're not adding anything here. So fair enough. Intervention, patient education. Clinicians should utilize patient education that, one, describes the natural course of the disease, promotes activity modification to encourage functional pain-free range of motion, and 3, matches the intensity of stretching to the patient's current level of irritability. The recommendation is based on moderate evidence. So you should tell them how long this is likely to take. You should, provide informed consent or attempt to provide informed consent to help you actively engage patient autonomy, which is required of you by healthcare ethics. So if you don't tell them how long it often takes for most people, or how it's highly variable between individuals and you're not sure how long it's going to take, but we can find out and we can consistently reevaluate, then you're messing with your ethics. So you should be doing that anyways. Promotes activity modification to encourage functional pain-free, or there's an old joke. I went to the doctor and I said, it hurts when I do this. And the doctor said, don't do that. Like, do something that you can do so that you're not constantly pissing yourself off and you're not constantly re-engaging the nociceptive cycle. Do something slightly different or move just short of pain. Adjust your activity. Everybody's going to do that. 3, matches the intensity of stretching to the patient's current level of irritability. If it hurts, it's your own fault. Hey, I want you to move and try to increase your range of motion, but stay shy of the pain response. Stay shy of it hurting you. If it hurts, it's your fault, not mine. I told you not to go that far, or to judge based on where it starts to hurt and stay in a range short of where the pain is. Intervention modality, and that is based on moderate evidence. Intervention modalities: clinicians may utilize shortwave diathermy, ultrasound, or electrical stimulation combined with mobility and stretching exercises to reduce pain and improve shoulder range of motion in patients with adhesive capsulitis. Recommendation based on weak evidence. So whatever. Intervention mobilizations. Clinicians may utilize joint mobilization procedures primarily directed to the glenohumeral joint to reduce pain and increase motion and function, and recommendation in patients with adhesive capsulitis. Recommendation based on weak evidence. So how that is written, I would remove the reduced pain. I would say that I would probably separate the constructs out. The question would be, in those with adhesive capsulitis, does mobilization of the GH improve range of motion? Then I would have something separate as a separate measure. Is there a change in reported pain? How often does it happen? So that I can have a better expectation and understanding of yes, it will, or yes or no, it will not change the mobility. And yes, it will, or no, it will not change the pain consistently, regardless of patient, or it will change sometimes, maybe at this rate, so that I can better inform the patient. Intervention, translational manipulation. Clinicians may use translational manipulation under anesthesia directed to glenohumeral joint patients with adhesive capsulitis who are not responding to conservative interventions. Recommendation based on weak evidence. So you can basically put them out and wiggle their arm a lot, and you can find videos of this where you'll hear lots of noises and see lots of clunks, and maybe it helps and maybe it doesn't. The evidence on this may be better today, but I have not looked. And moderate evidence. So the only thing that has strong evidence is corticosteroid injections. So the RCTs in medical land are probably decent, especially with respect to corticosteroids, in combination with mobility versus mobility alone. What's recommended? And the strong evidence is the outcome measures. So standardization of procedure. So if you use the same measurement tool, you are likely doing the same thing over and over. Your validity is high, but that doesn't necessarily mean it's going to improve clinical outcome. It just means that your measurement is more trustworthy. So take from that what you will. Is this the right one? Yeah. Another one, physical management of non-traumatic shoulder problems lacks high-quality clinical practice guidelines. A systematic review with quality assessment using the agreed-to checklist. When's this from? This is from 2021. To read the abstract, objectives: to appraise the quality of clinical practice guidelines for physical therapy management of non-traumatic shoulder pain disorders. So we were looking at non-traumatic shoulder pain disorders before. Maybe I'm messing something up. Anyways, design, systematic review of CPGs. So if you know systematic reviews, you know what the design looks like. Literature search. 2 reviewers independently conducted a research of 7 databases and 7 gray literature sources. Study selection criteria. We included systematically developed CPGs, so it had to be done by systematic review. It had to be done based on something that would be considered systematic. Developed CPGs for physical therapy management of non-traumatic musculoskeletal conditions of the shoulder in adults that were available in full text in the English language. We excluded CPGs for physical therapy management of surgically treated shoulder pain disorders. Data synthesis. 3 reviewers independently rated the quality of the CPGs using the appraisal of guidelines for research and evaluation to the agreed-to instrument. Data were compiled into tables that displayed agreed-to domain scores for each CPG and mean item scores across the CPGs. Results. We included 9 CPGs, 5 CPGs focused on rotator cuff disorders, 2 focused on frozen shoulder, and 2 covered a range of soft tissue shoulder diagnoses. The 3 CPGs were judged as high quality. All were 5 or more years old, and 6 were judged as low quality. The quality domains of in which CPGs were rated highest were scope and purpose. All CPGs scored greater than 50%, and 4 scored greater than 80%. Clarity of presentation, clarity of presentations. All CPGs scored greater than 50%, and 7 scored greater than 80%. The domains in which CPGs were rated most poorly were applicability. 6 CPGs scored 40% or less, and editorial independence. 4 CPGs scored less than 40%. Conclusion: there were no high-quality contemporary CPGs to guide physical therapy management of non-traumatic shoulder pain. Contemporary. I think that just means less than 5 years old. 6 were judged. What? Hold on. 6 were judged as low quality. Yeah, 3 were judged as high quality, but they were old, so there's nothing contemporary because it's old, right? So the recency seems to have some impact on what would be considered high quality. The challenge with that is if something was figured out a long time ago and it was high quality, it is likely to remain high quality. So some of you may or may not have heard of something called the Lindy effect. The longer something is around, the longer it is likely to stay around. So if something has been utilized for 2 years, it is considered likely to last at least another 2 years. And at the point you get to 4 years, it is likely to last another 4 years. Obviously, there's caveats to that and edges to that, but it's just a general thing where sometimes things could be considered timeless or ageless. Yeah. I think it got knocked down because it was old. A systematic review. So the next one, the final one, a systematic review of clinical practice guidelines on the diagnosis and management of various shoulder disorders. And this is from, 2023. To read the abstract here, the objective, to perform a systematic review of clinical practice guidelines covering the management of common shoulder disorders, data sources. A systematic search of CPGs on specific shoulder disorders was conducted up to 2022 in relevant databases. Study selection, 26 CPGs on rotator cuff tendinopathy, which is rotator cuff tear, calcific tendinitis, adhesive so this is listing them all. So it's not separating them out. Please excuse me. 26 CPGs on rotator cuff tendinopathy, rotator cuff tear, calcific tendinitis, adhesive capsulitis, glenohumeral instability, glenohumeral arthritis, osteoarthritis, or acromioclavicular disorders, published from January 2008 onward up to 2022, were screened and included. Data extraction. CPGs methodological quality was assessed with the agree-to checklist. All recommendations from CPGs were extracted and categorized by shoulder disorder and care components evaluation, diagnostic imaging, medical rehabilitation, and surgical treatments. After semantic analysis of the terminology, recommendations for each shoulder disorders were classified by 2 reviewers into recommended, maybe recommended, or not recommended. Disagreements were resolved by discussion until reviewers reached consensus. Data synthesis. Only 12 CPGs, 46%, were of high quality with major limitations related to the applicability and the editorial independence of the guidelines. The initial evaluation of shoulder pain should include patient's history, a subjective evaluation focused on red flags and clinical examination. Like, no shit. Magnetic resonance imaging is usually not recommended to manage early shoulder pain, and recommendations for x-rays are conflicting. So don't use imaging early because it could create probably psycho-emotional stuff where the patient can really lean into the image. Clinically speaking, I have experienced this quite a bit when people have image reports. They haven't necessarily seen the image, but they have the report, and people don't necessarily walk through the image report, so I walk through it with them to see what they do and don't understand, and also provide them with the information that just because it says this doesn't necessarily mean that's why you're feeling this. They're happening at the same time. They're at least related in that way, but yeah. To read again, acetaminophen, oral non-steroidal anti-inflammatory drugs, and rehabilitation, including exercises were recommended or may be recommended to treat all shoulder pain disorders. Guidelines on surgical management recommendations differed. For example, 6 CPGs reported that acromioplasty was recommended or may be recommended in chronic RC tendinopathy, rotator cuff, whereas 4 CPGs did not recommend it. So they don't necessarily agree. The CPGs, they're supposed to be done in a way where agreement is present, and you would assume that if people were using the same method that they would come to about the same recommendations, but maybe that's not the case, or they're using different methods to come to them. Conclusions. Recommendations vary for diagnostic imaging, conservative versus surgical treatment to manage shoulder pain, although several care components are consensual. The development of evidence-based rigorous CPGs with a valid methodology and transparent reporting is warranted to improve overall shoulder pain care. So the reason that you would say that we should do this the same is because it does improve validity. Because if we do the same thing, we're likely to come to the same finding. That doesn't mean that it's correct, because you have to make a lot of choices to get to the methodology of what we're going to do the same. Those choices are value-based and may not reflect the reality of clinical practice in any given moment. But if we do it the same way, we come to the same conclusions, then we have agreement. And that is probably more the focus. EBM and EBP are definitely positivist. They believe that there is a singular reality, or the epistemology underlying, the epistemology being the theory of reality or the theory of truth, which requires you to figure out what can be known, how it can be known, and who it can be known by, such that the fundamental concept of positivism is there is a singular reality. It can be identified with appropriate experimentation, and the experimenter is the issue. So we need to have the same steps so that we wash out the impact of the experimenter, because the experimenter is always the problem. When applied, we still see variance in raters or experimenters. When applied, we still note that although everybody falls into the category that we're studying, they're different than one another. So if I'm studying a particular group or a particular condition, what ends up happening is they're all the same because they all have that condition, but they're all different. And we see that variance in the data that we collect, such that although we can come to recommendations, those recommendations have to be broad. Otherwise, they're useless because they can't apply to the variable patient population that comes in under the construct of the condition. So the CPGs are hard to make. They're hard to be useful. They're hard to not have the underlying flaws of personal preference of the people that are creating them, or say the ideological drive or the personal drive, the interpretive challenges of being a human, the monetary challenges of being a human, because if you've got a particular organization putting it together, they might have relationships that would be monetary in nature that could impact how they put the clinical practice guidelines together, because what they're trying to steer people towards is a particular thing that they're going to make a little bit of money off of. It doesn't mean you shouldn't try to get to some form of agreement, but it does mean that in the process there are knowable flaws. So really leaning into the process being the same isn't necessarily going to wash away the variability. We can see the variability within the systematic reviews because the processes aren't exactly all the same. We can see that there are issues with how clinical practice guidelines are generated, and we saw a few that used the agree to checklist, and the agree to checklist is the thing that's showing this. So there's just this consistent push to figure out ways to make everybody do things the same, because that's the underlying value of positivism. Again, I want it to be clear. I like positivism. If I had a preference in epistemologies, it would be more in the direction of positivism than constructivism. However, constructivism, which posits that truth or reality is based on the observer, the previous experience of the observer, and the current environment of observation of the observer. So truth is much more individualized. That does come into play. It's one of the reasons that in EBM and EBP, they've included and kind of poked in the direction of patient preference, but patient preference is already cared for as a fundamental construct in medical ethics or healthcare ethics by autonomy. So it's already there. Because patient preference is behaviorally going to predict more what the patient will say yes to, as opposed to what the patient will run away from. So it does matter, because if the patient will take no treatment, then nothing positive can happen. So you have to consider the patient and their variability anyway. So people have to include it, but it's an omnipresent phenomenon. So I think there is great value in standardized assessment approaches and variable treatment approaches because the patients are different, but the standardized assessment approach will allow the individual doing that to have at least high intra or within themselves rate of reliability. So I use the same tests over and over again, so I'll know when there's something different about the test because I run it all the time. I can trust myself. If we all run the same tests, then inter-rate of reliability goes up. However, the challenge there is the assumption that the tests that everybody runs all the time are appropriate to the circumstance or appropriate to all circumstances, where realistically, you're going to have to change your assessment approach depending on the presentation of the individual. You should have a standard approach that you do almost all the time when you can, but you're going to have to adjust it from time to time due to edge cases and clinical reality. So intra-rater reliability within myself, I can build with ease. Inter-rater reliability is much harder because it's hard to get people to agree on stuff. So, and also it's harder to have anything that we all do be the correct thing for all circumstances. It's correct for some circumstances, but we still have to have the skill to adjust to the needs of the current circumstance. So the point of this was to show that there are issues with clinical practice guidelines noted through standardized approaches to clinical practice guideline development because they're variable, unfortunately. And when you use the same checklist, you find that there's problems. So when you use the agree to checklist, you find that there's consistently problems. And that's only on shoulders. It's probably the same in other areas because of how these things are developed, right? And one of the things that they're knocking points off for is the stuff's old. So what if it's old? If it's working, it's working. I don't need to update it because the substrate hasn't necessarily updated because the substrate is humans, right? We don't change that much on a short time scale, physically anyways. There may be cultural changes on very short time scales, but that's a different thing. So just keep in mind that clinical practice guidelines or best practice guidelines, if they have any evidence supporting them, it's because it was developed in a completely different way and somebody's just importing it in there. It was developed through basic science, especially in the form of randomized controlled trials or other forms, but randomized controlled trials is going to be what the EBP people like the best. Totally fair. I get it. I agree for the most part. The evidence that CPGs do anything isn't really contained within the CPG. It has been identified prior, if it exists at all. And then in aggregate, what I've seen with when the application of CPGs are studied, the application is variable between physicians, or between practitioners rather. So I have low confidence that the actual application in aggregate of clinical practice guidelines really holds much weight. I do have confidence that those things that are considered high quality evidence that may be contained within CPGs is there because somebody else did the foundational work. And I'm fine with that. I can get on board with that. But yeah, I don't have high confidence that CPGs show me that they improve patient outcomes because they're synthetic. They're brought together from other sources and said, hey, this looks good over there. If we slap it together, it should work out really good. That's not what I'm seeing. And they're abstract to the point where I don't know that they actually add anything above and beyond basic clinical skill. Maybe they do. I'm not seeing it. My confidence isn't really high in any of that. So is it fair to say that some clinical practice guidelines or some best practice guidelines have evidence supporting some of their subcomponents? Absolutely it is, but it's because it was developed in a different context and imported in a synthetic way. Is it fair to say that in aggregate, clinical practice guidelines show improvement above previous treatment approaches? No, because that's not what's studied. It's just synthesized and imported. So because of the complexity of clinical practice, because of the complexity of humans, it might actually change when you bring things together in that manner and suggest people work this way. Doesn't mean that they will, doesn't mean that if they do, it's appropriate for the situation presenting clinically in any given moment. It's more complex, with complexity being you may understand how each subcomponent works, but when you put them together, they will do things that you cannot predict, right? So unfortunately, my confidence has not been raised. Part of me hopes that this is the last time I look at CPGs for this purpose. Maybe it is, maybe it isn't. If you've been listening, I appreciate that you listen. Hopefully you look yourself instead of just trusting me. I'm showing you the process of what this looks like, not telling you that you need to agree with my process or that you need to agree with my considerations and my interpretations. I would rather you take this as an example of what this looks like than to lean into my interpretation. Don't listen. Oh, that's not right. Don't take at face value my interpretation. Gain the skills so that you can check if my interpretation has any value for you. So if you've listened this far, thank you very much. Hopefully you've learned something, and we will talk again soon.